Welcome everybody to National Informal Discussion Group for Personalised Cancer Care. Nice to see you all. My name's Sandra Dyer. I think I know most people on the call, but I'm clinical advisor for Wessex Cancer Alliance and a primary care nurse by background. And just quick spiel about the group. So welcome to any new members. Do tell people about this group. So on paper we have about 80 members now. Obviously people can't always make every meeting, and we record the sessions, so they go onto the WCA website, which I tend to share the recording afterwards. So do feel free to share that with others if you think it's of interest to them, and invite people along to join the group as well, which they can do via the web link. It'll be quarterly, so our next meeting will be in June. I guess just to kind of reiterate the kind of informal meetings, we want people to kind of take part in conversation and debate. So there will be plenty of time today for that. You can either use the chat or raise your hand at the end of the presentation, and then we can start a conversation off around the topic. So just to say, we've had a slight change of topic, very much aligned, but not quite what we planned. So initially, Jane Winter, who's Director of Nursing and Allied Health Professionals for Wessex, was going to speak about the cancer plan. Unfortunately, she wasn't able to make today, and Teresa very kindly stepped in. So Teresa is Programme Manager of Personalised Cancer Care at Wessex, and she's going to be talking about neighbourhood cancer care. So I'm going to hand over to you, Teresa, at this point.
I don't want today to be too much kind of PowerPoint, but I just wanted to kind of give a bit of context with some slides, and I'm happy for these to be shared. So as you'll all be aware, the cancer plan has it links to the 10-year plan, and one of the key shifts is around moving care to neighbourhoods and communities as much as possible. So what we've been doing in Wessex is trying to think a little bit about what this might look like, what already happens in communities, what could happen in communities, and so that's what I'm going to talk about today, and just to share some of the feedback and the thoughts that we've had on that work, and I'd be really interested to hear your views and how it feels to have this coming down the track as well. So I guess in terms of just a little bit of background, why now? I mean, I'm sure any of this won't be surprising to you. We know that there's increasing numbers of people living with cancer. We know that a lot of those people have other things going on in their lives in terms of multimorbidity, frailty. We know that there's more health service use and emergency department attendances. We know that people are using health services more than the capacity is there for. And we know that a lot of work already happens in primary care and in neighbourhoods, and that there's a lot happening in terms of a role for primary care in terms of continuity, coordination, and potential for that work to be perhaps expanded upon. And neighbourhood health, a framework was published last week. I'm not sure if any of you have seen it, but it's very much now a national expectation, and the goal of it is around improving outcomes, continuity, access, reduce inequalities by moving as much care as possible closer to where people live. And cancer care was mentioned specifically in that framework that was published. I don't know if we can share a link of it in the chat, but I'm happy to dig it out if people haven't read it. But cancer care is specifically mentioned, so there is a kind of a national directive now. So again, not a huge surprise to you in terms of why this matters for primary care. A lot of the time, it's the first point of access, or where people present with early warning signs or red flags, and this can be either before diagnosis of cancer or for people with late effects, or for issues after their diagnosis. We know that where there are neighbourhood teams, beyond primary care practices, where there's neighbourhood teams in place, that they do a lot of work around proactive care to reduce crisis presentations. There's potential there to reduce some of the duplication and confusion that happens across pathways if we can articulate how this might work in a way that clearly aligns secondary care into the community. There's huge potential there to improve coordination of care. There's also potential to have faster access to specialist advice to support decisions, and to link that up better. And we know that in primary care, the you know what's going on in your communities, which means that for secondary care providers, there's if we can join up that link and we can have people working well together, there'll be better links to local holistic support options for people as well. And across the board, all of this will facilitate an improvement in patient experience. So it's about improving neighbourhood care, but also ensuring that care is coordinated across secondary and primary care as well, as part of that shift. So just in terms of the National Neighbourhood Framework that I mentioned, these are some of the key goals. So again, probably not that surprising that these are the things that they're trying to achieve, but it's about proactive risk-based support. So really early identification of people who might be likely to present at an acute service. So any way that we can support that is prioritised in the National Neighbourhood Framework. Linked to that is continuity and joined up care. We know that there's a lot of missed opportunities for people where care is fragmented, where information isn't transferred as quick as possible, or people are not being referred to the right person at the right time. So those are kind of the goals and the ambitions of this plan. And it's all linked to reducing avoidable hospital activity, which again is linked to patients and carers having better experience. Most people do not like having to go into a hospital for all different sorts of reasons. And by providing care closer to home, there's a real opportunity to improve that experience for people. But there is a lot of fear, I guess, and concerns around this. We know that primary care teams are stretched, and new models can feel like another thing to add to the list. And there are really valid concerns about a lot of work being pushed onto primary care teams that they haven't traditionally had to do, and how and concern about how that will look as we try to develop these neighbourhood models. So people are worried about workload, they're worried about a lack of clarity about the expectations of their role, they're concerned about their capacity, but also their skills in relation to talking about cancer. Not everyone feels confident in having a conversation with about someone's experience of cancer. There's a fear of either duplicating work or confusing or creating complexity in a person's pathway by referring to something or not joining up across, if they can't see records of somebody in secondary care and so on. There's concern about that. So I guess when we are talking about all this, we have these things in our mind. We are aware of these concerns. And when we're trying to design what neighbourhood cancer care might look like, we have these concerns very much driving kind of what we're trying to do. And the attention is very much not to move more cancer work into primary care. It's more about having clarity about the roles, about upskilling to the extent that primary care needs to be upskilled, but also recognising that there's a lot of specialist knowledge that is not appropriate for people of in primary care to be expected to have, and that we just have clearer pathways and clearer role boundaries about what you should and could know, versus at what point does somebody need to be referred into a secondary care specialist centre. And we're also thinking about what specialist outreach could look like, and it's effectively it's all about trying to get the right work in the right place and supporting people in their roles to deliver care in that way, and to know who to refer to and what's available, what the appropriate referral or signposting might be where possible. So at the moment it feels a bit I guess nebulous because it hasn't been pinned down. The framework that was published last week I think will help drive some of those changes forward, but these concerns remain, and it's, I guess, our work together is to try and figure out how we can overcome some of these concerns as we're developing models of neighbourhood cancer care. As I say, the guidance really does clarify around kind of some of these things. The aim of MDTs, for example, is to reduce, not to increase workload. So it's about being working together to make things more effective and efficient. It's about having clear pathways. It's a real emphasis on proactive care and thinking about how we can do that so that people don't reach crisis point. There's a huge emphasis on using data and digital tools to support teams, to identify people who might be at risk, for example, or to even to use things like AI to spot people and look at records and flag up people who might need to be seen proactively. And again, the idea is around reducing inequalities, because we know a lot of people really do struggle to access care, and where care is happening closer to where people live, there's a real opportunity to support them. So it's not about putting more work into primary care practices either. I guess that's important to note. The idea is moving it to neighbourhoods. So there will be neighbourhood teams thinking about the wider community teams that are there, and also specialist outreach moving out from secondary care to support that. So it's not that it is expected that primary care practices pick up all this work. It's really about reimagining what a neighbourhood team might look like. This slide, I guess to reiterate some of those kind of existing strengths and opportunities we have alongside the weaknesses and threats. So we did a SWOT analysis. So I think it's important to reflect on both of these, the positives and the negatives. There are places and pockets of really good, strong MDTs already. We have strong screening programs. There are neighbourhood and community models emerging or already existing that we can learn from and build on. There is a culture in many areas of innovation with digital tools. Certainly down here, Dorset is an example with their DICE platform. So there's things there that we can pick up and learn from. So we're not starting from scratch. And obviously, even networks like this demonstrate that there is a real appetite for collaborative working and sharing and learning from each other. So we're not starting at zero, and there's no need to reinvent the wheel. I guess the threats or the weaknesses that we've identified is around workforce capacity, and specifically around cancer roles, but also in terms of people's confidence and ability to work with people in cancer in primary care, and fragmentation, as I've spoken about, as well as obviously resource and financial constraints or weaknesses as well. The opportunities at the moment, there's a huge emphasis on this in terms of national policy. It is kind of central to a lot of the planning that is happening when people are talking about, the other two shifts, analog to digital, that will support the neighbourhood working by sharing records and supporting people to self-manage using digital tools and report and monitor symptoms using digital tools, and also in terms of the from treatment to prevention, that proactive care sits in the neighbourhood as well. So the other two shifts are almost underpinning this wider shift for neighbourhood care. As I mentioned, there are huge opportunities with digital tools to support that. And we also know that there's existing partnerships with VCSE organisations that can be developed further and harnessed to support people in a way that perhaps they haven't been really recognised before, and there's real opportunity to work more closely with them. We know that there's other threats. There's persistent inequalities in access. We know that there's increased complexity, like late diagnoses still. We know that there's a potential threat of role uncertainty where boundaries get blurred and it's not clear who should be taking the lead in supporting somebody. And there's also that potential for maybe tensions around that, where traditional roles might change or flex in some way, and it might cause kind of, I guess, a threat to some of that collaborative work that we've seen before. So there's something about being really clarifying, as I say, that pathway, who steps in where, when, who's the right person, and trying to articulate that to support somebody with cancer, and to have it, we talk a lot about having no wrong door approach, where whoever you see first will be able to refer you to the right person to support you in an efficient way. So it's very much this idea of this quote from Arthur Ashe around start where you are, use what you have, and do what you can. We're not going to change the system overnight. It's would be too difficult to do a huge overhaul, and very much the attitude we've adopted is to think about what we're doing already in neighbourhoods, think about all of the good work that's already happening, and trying to bring all that together and just figure out how we could tweak it slightly, or support it to just tie up some of the threads across the services. So we know that there's a lot happening already. Doesn't need to be an influx of 10 new services. It's more, can we just tie up the bits where things are perhaps not as joined up as they could be, and really using what we have and doing what we can to start with, because there isn't a huge, despite all the policy, there isn't a huge ton of money coming to support this initiative. So we really need to just start with where we are currently, and looking across our region, identifying what we have. And neighbourhood care will really grow from what teams already do well. So we're just trying to develop that. So we've developed an approach based off that work that we've been doing. It aligns with the national requirements, focusing on things like proactive care, prevention, and reducing inequalities. It's all about local delivery of cancer care. So really looking at what work INTs, integrated neighbourhood teams, are doing, what they can do to support personalised cancer care, looking about what populations are in which areas, so that you can take a targeted approach. So thinking about resources that might be needed in certain areas. And even just this morning, I was on a call with somebody about a community oncology service, where in some areas the focus is on very much delivering treatment. In other areas that are more rural and people are more socially isolated, it's more on psychosocial support in terms of the offer and that they provide. So there's variation based on what is required by the different neighbourhoods as well. So there's something about being flexible and responsive to the local needs as well. We're thinking a lot about how we can develop what we're calling kind of a cancer confident or cancer literate neighbourhood workforce, so that people are comfortable talking about cancer to a certain extent to what's required for their role, and that they know enough about cancer that they can speak to someone in a safe and confident way, but that they know who they can then refer to, or what might be an appropriate next step for them. And also we're looking at how we can use data and digital to support what we're doing as well. Another, I guess, important thing with the work we're doing is a distinction between community-based cancer care delivery and the work of integrated neighbourhood teams or primary care. When we talk about the community-based cancer care delivery, we're talking about that activity that currently happens in secondary care that could happen in the community. So what could we move from a hospital into a community setting? If we could access the estates to do it, or local community hospitals, community centres, all those kind of things, what could we move out of hospital? And then the flip side of that is looking at what already exists in integrated neighbourhood teams and primary care. And I think this distinction is quite important, because it really demonstrates that we're not expecting integrated neighbourhood teams and primary care to pick up everything in the cancer pathway that's going to be in communities. We recognise and expect that there will need to be this outreach from secondary care, where specialist teams can do things like deliver anti-cancer treatments in the community, that some outpatient appointments could potentially happen in communities, and that things like late effect services could be supported in communities as well. And also where psychosocial and care planning support could happen in communities as well. But these would be outreach from the secondary care teams. The integrated neighbourhood teams and primary care teams is very much about the wider neighbourhood health model, so how we can reduce risk factors for cancer, how we can recognise signs and symptoms, how we can support people to attend their appointments, how we can support people who are having treatment with kind of early toxicity management and make sure that they're linking into acute services as they need to proactively be identifying and supporting people for late effects. So being aware of people on their patient list that have had treatment for cancer and recognizing that some of the things that they might present with might be linked to a cancer or treatment they've had in the past. And then things that, again, already happen in terms of social prescribing, behavior change support, and looking at what could be offered in terms of voluntary organizations in terms of prehab or support for self-care, finances, and so on. So there's a huge role to play, but the work of integration neighbourhood teams is distinct from that work that we are articulating as kind of being outreach from secondary care. In terms of what this means for a patient, it would mean better coordination and support to stay well before, during, and after treatment. And with that, it would be kind of a single biography through the care journey that, you know, a person doesn't need to repeat their story multiple times, that the care is flexible and responsive to fluctuations over time, and that people have this access to streamlined support and timely escalation to the right person. You know, I've repeated that a lot, but I think that is the key to a lot of this, is who is the right person at the right time, who can deliver the right intervention for that person. So it's about being proactive, responsive, and personalised, and having that multidisciplinary approach. And obviously then I guess that would mean less need to travel to hospital, reduced, disjointed, fragmented experiences, less likely to have these kind of support cascades where lots of people, lots of teams get involved because care isn't properly coordinated, which can be extremely overwhelming for people, and can lead to poor outcomes for people, particularly those with complex needs or multiple co-occurring conditions. In terms of developing that cancer literate or that cancer confident workforce, we're looking at our workforce offer around how we can use our Wessex Cancer Academy training to support people, and looking at Ascend to set consistent standards about what's expected of people. We are going to increase the development opportunities for people working in primary care. So thinking about things like communication, late effects, personalised care skills, support with things like managing multimorbidity and frailty alongside cancer as well. And we're also looking at what boundary spanning roles might look like, how they might work, how people might work in and out of primary and secondary care, and also mentorship and peer support opportunities as well. So I guess in the short term, what we're looking at is about building the foundations. So looking at the INTs that are developing and cropping up around us, and thinking about how these can be cancer informed, how we can train the workforce, how we can continue to promote the work we've already been doing about screening and early diagnosis, how we can design and deliver prehab services and rehab services, and how we can continue to develop outreach models like Right By You, which some of you might be familiar with, which is a service that we have in Wessex. In terms of the medium to long term, what we're looking at is really expanding what that offer might look like, scaling up things like delivery of systemic anti-cancer treatments, extending personalised stratified follow-up and remote monitoring, and using that advances in digital to help people to do the responsive monitoring in relation to their outcomes and experiences. So completing kind of little surveys while they're in the community and flagging up any potential concerns. And ideally, in the long term, all of this is designed to improve survival, improve pathways, and develop more sustainable neighbourhood cancer care models that's equitable and kind of driven from the community side of things as well. So if we can do this well, the idea is that we'll have the right work done by the right team. There'll be earlier intervention, which will reduce crisis, and it will hopefully streamline the work of primary care and help to make things more sustainable. We know that people currently have, people with a cancer diagnosis account for far more primary care appointments than we would expect based on the number of them in the population. Using 2 to 3 times more primary care appointments than people without a cancer diagnosis. So it could, if done right, really support primary care capacity and also support people's experiences. So that's it for me. As I said, I'm very happy to share the slides. Thank you for listening. I guess my question back, and I'm happy to take questions, but I think it would be really helpful if anyone has any thoughts about what might make it easier for you in your teams, or perhaps what's not there currently that you would need to support people with cancer in your neighbourhood or your area or your practice. So yeah, that's all from me. Thank you.
Thanks, Teresa. It was very comprehensive, informative, and I learnt lots about the neighbourhood teams. I didn't know about the new framework, for example, so it'd be really useful to maybe if you can share a link with us, we can share it with the group. Be a good starting point, I think. So people have put a couple of things in the chat, and I'm also mindful of your question, Teresa, which you might need to remind me what it was, or pop it into the chat.
Yeah, I'm happy to.
You've taken it down. Thank you. So for those who've popped stuff in the chat already, does anybody want to speak to their point? Or I might put people on the spot. Jackie.
Yeah, happy to. I mean, I guess I feel slightly frustrated listening to that. Not because of you, Teresa, or anything that you presented, but I think I've been in cancer for too long. I think sometimes to just think this is just feels like Lego bricks that somebody's broken down at Legoland and just reconstructed in a different way. Because at the point where we had QOF money that was, allowing us or enabling us to pick up newly diagnosed patients within the first 3 months of diagnosis. And then, following that through within 12 months of diagnosis, we were doing or certainly I was personally doing all of those things. And I've been a secondary care nurse. I've been a cancer nurse specialist. So I've worked in secondary care, at that level. I've also worked in primary care. So I absolutely know how the two can link together. Certainly my experience here in Oxford is that the secondary care teams are so snowed under. The chance of them getting sacked, rolled out to kind of, neighbourhood centres in any way. We've been asked before here at this practice, which is purpose built and new in the last 10 years. There is no capacity building wise to do it. And there certainly is no capacity in terms of the sacked workforce to actually have enough of them to be able to do that in any sort of meaningful way. So the theory is great. And I mean, don't get me wrong, I totally support everything you said is where we want to go. But I'm just very sceptical about the money and how realistically that's going to be any different to what we've had before. So sorry if that sounds a bit negative. I don't mean to be.
No, and I think it's really important to be realistic about all of this. I think it can feel a bit pie in the sky otherwise, so it's really helpful to hear your views. I know a lot of the work that's happening here in terms of the SACT is looking at opportunities for how we can increase prescribing of medications that people might be able to self-administer. And I think maybe down the line that might be one opportunity when it comes to SACT. I think support for the number, the staffing is obviously really important as well. We are looking at moving some of the services into local community hospitals, even just a day a week or a half day a week to have clinics. But I think from the teams that do that already in our area, what they've been talking about is, can we reduce the number of people having treatment that requires IVs, where they might be able to take subcut or take it in another form, so that, and working with patients so that those patients who could self-administer if they were shown how, that maybe kind of ups, training them to do it and supporting them to do it for the first. So I think that's the way they're coming at it with that side of it. I mean, it's not my area of expertise at all, but I guess it's just trying to think about what's possible with those. And I don't know down the line if those ways of delivering SACT might change as well, much might support it. But I totally acknowledge your point. It's not going to happen tomorrow. Absolutely.
I mean,
not.
I'd quite like to come back to you on that, because I mean, I've worked at Healthcare at Home as director of nursing. We were able to give about 80% of most IV regimes at the moment in the community safely, even if it meant that their first or second infusions had to be given in hospital. But once they were shown to not having toxicity, the downside of doing subcut oral or anything else is that people think therefore it's less toxic, and in reality the toxicity is usually the same. So unless you've got services out in the community that can manage that toxicity, then actually you're just kicking the can somewhere else, but the problem doesn't go away. And also patients are then left floundering sometimes when they do get toxicity, to know, well, who do I contact, and invariably that ends up being through either acute oncology services, or the chemo suite, if that's kind of how it works in that particular area. So again, you're kind of just moving the problem, you're moving the bricks around again, the players around, but the problems don't change.
Yeah, totally recognize that. Yeah, I think, and that's what I mean about kind of, it almost has to be thinking about the whole pathway, doesn't it? It's not just thinking about isolated elements of it. It really has to all join up together. Yeah, thank you.
Does anybody else like to come in? I've seen a couple of people put comments in around not really hearing very much in their systems about what neighbourhood teams are doing. So kind of interested to hear about that, and whether whether those kind of links are existing already. Tanya.
Yeah, that was me. And yeah, so we've got 2 of our places are pilot sites, and it might just be that I've not heard of anything myself, but I haven't really heard anybody else in our alliance sort of talking about, anybody talking about cancer or what we can do. And I just wanted to follow up on Jackie's point, really, which I think we're all acutely aware of, are the financial constraints. I know particularly, so I'm from Cheshire and Merseyside, and we're one of the worst performing ICBs in the country financially. And I know locally, so for example, we do deliver some SAC treatment out in the community, out in people's homes. And I know the intention is to do more, but we've got less AO nurses than we had 2 years ago. We've got recruitment freezes. You just kind of wonder how any of this is going to happen and improve. And I think I said in my comment as well that we're introducing a frailty program at the moment, which everybody signed up to. Somebody from the ICB is the SRO, and yet we still know, even with that kind of commitment, without funding, it's not going to happen, and it's not going to change anything. It all feels very sort of doom and gloom at the moment. And I've worked in the NHS for over 30 years, and we've always said it's on its knees, but I've never known it as bad as it is now. Some of our trusts, they're not replacing clinical staff, and I've never ever known that happen before. So I just don't know. Sorry, that is all very doom and gloom, isn't it? It feels like that's the reality at the moment.
Yeah, no, that it totally makes sense. What we've been doing we have 2 pilot sites for the national implementation pilots in Wessex as well. And what we've been doing is, they haven't prioritized cancer as one of their areas of focus. A lot of them have focused on things like frailty, multimorbidity, mental health. And what we have offered to them is to support them and say, well, actually, a lot of the people that you're going to be meeting are going to be people that have cancer as well, and kind of working with them that way. So it's kind of, I think there's something about going with whatever the movement is, and kind of, for lack of a better word, bandwagoning a little bit on what they're doing, and where they are developing initiatives to support frailty, for example, thinking about that might impact cancer and how cancer works alongside that. I think the SACT challenge is a huge one, and that movement out in terms of treatment is huge. But I think there's potential with the work that's already happening in communities, thinking about what voluntary and community organisations do in terms of the supportive work, that perhaps we need to just tie up a little bit more. I know you can't have an over-reliance on the voluntary sector either, because they're in a similar state. But I think there's something about linking in all of those things and just trying to figure out what's what's happening, because I think we don't have a sense of all the fantastic work that's happening that we could harness, and trying to think of it in terms of better ways of working where possible, as opposed to trying to develop new services when there's no money, no time, no staff, trying to figure out, and I guess trying to understand more of what's happening out there.
Thanks, Teresa. Pip, do you want to come in?
Yeah, I suppose I'm completely agree with what you said, Jackie, and it is the frustration of continuing to work in primary care over all these years. It's just reinventing the wheel. But I do like your Lego analogy. I'm going to bag that one. I think I'm just going to go slightly off tack a bit, because my interest is specifically in looking at the early diagnosis in the underserved community, or demographic, and I work with the special allocation scheme patients who are notoriously difficult to engage with, unless it's completely on their terms, of course. So the mobile outreach type of concept I'm really interested in, and whether that could be used for both, use it for the earlier diagnosis of some of our more harder to reach patient group, as well as your treatments, and can we combine that at all? My patient demographic aren't particularly community friendly, shall we say, so they don't necessarily want to mix. Well, regular members of the community will not want to mix with my patients, but that I think there's room or capacity to do something. The trouble is with and I think it goes across most of the SAS teams in the country, in that we cover a huge geographic patch. So I cover Hampshire and the Isle of Wight, so I've got patients that will not travel to a clinic. We obviously have to rent a room in the GP surgery to see patients. Half the time they don't turn up because it's too far for them to travel, they can't afford it, and all these sort of other reasons why they won't turn up. And so they're not coming with their maybe their early signs or symptoms either. So we've got that kind of aspect, as well as see, I live in quite a semi-rural area, and as we know, patients or people just can't get contact with primary care for whatever reason, so they just give up. And I've got some like older neighbours here who have tried to get through to a GP or to primary care to get an appointment because they're a bit worried about something. They can't get there. Either they can't get through online, they can't get through all the hoop jumps, so they just don't bother. So they haven't bothered. So again, is that in the sort of community outreach kind of? Can we incorporate anything? I don't know. I'm just kind of throw it out there a little bit. So concerned about our underserved patients.
Thank you, Pip. Tracy, do you want to come in?
Yeah, I'm Tracy. I work in a PCN, a large PCN. We've got 59,000 patients in Dorset, and it's all very positive here. I've been in post coming up 4 years as a cancer nurse, so I am a point of contact for patients, and we decided that despite the 3-month and 12-month QOF going, that we would still continue to do that. So for the patients, they've got somebody at point of diagnosis, and actually for many even before that, as a point of access. So and that's worked really well. But because I've been enrolled, we've also been able to work really closely with our alliance regarding screening and earlier diagnosis. So we have run a lot of pilots and projects locally that have really benefited, again, our patients and sort of early diagnosis. The neighbourhood, integrated neighbourhood, we're already doing anyway. So it's just, it's a name change. I think the only thing I find frustrating is more around the secondary care not wanting to give up some of their their roles and work. For instance, we ran a pilot for cytokine to diagnose esophageal cancers early, and we actually screened 150 patients within our locality, and that costs £300 a test as opposed to £1,000 a test for an endoscopy. And they've sort of held back in terms of implementing that into the community, even though we've got capacity, and that could be something that could be done in these diagnostic hubs or within surgeries. And the other things are just the day-to-day patients waiting for treatment to start. So we've merged, Paul and Bournemouth Hospital have merged into one UHD, but capacity hasn't increased, which just seems madness considering, as you say, the numbers are going up, we're diagnosing early. So patients are still very much reliant, unless they're on like immunotherapy or something that might be given in the community by the drug companies, having to wait. And other things like iron infusions, they might wait 6 weeks to go in because it's all being done within secondary care, because they closed a lot of our community hospitals. So from a PCN and from a cancer perspective, we're doing things really well in terms of support for patients, and have shown that actually the screening, the early diagnosis, do a lot of education with our other teams of Dorset Healthcare and secondary care, but also we've made sure we've got palliative care meetings set up, do a lot of work with our local charities. So it works really, really well. It's a really good model. But obviously there's areas that need to be improved. But as I say, that's more around secondary care.
Yeah, and that's certainly something that we've heard as well about, yeah, the kind of who, as I say, who takes ownership almost, and where the governance sits and where the money sits, and where the activity sits and all that is, and I think that all needs to be figured out. It's still quite early, but I think the fact that, and exactly the type of thing that you're talking about, that proactive management and support of people, and that holistic support of people when they're not in secondary care is really important. And it's just, how do we build on models like that? Mm-hmm. How can we take the best of what's working and build on that? Because we're not going to be able to change the system overnight. There's no money. Whereas if there is examples of good practice that just changing things slightly have made things easier and have improved things for patients, how do we share that learning, and how do we build on that? But yeah, I mean, it's great to hear that work that you're doing, Tracy. Absolutely. And I think it's a really good example of that proactive approach, that if we can get in there early, actually, or if you can have those regular meetings with people, that exactly the loss of the cancer care reviews has been unfortunate, but if you can have those meetings still, you're probably saving other appointments where those people will show up anyway,
Oh, completely, yeah. And we found that it's the continuity of care that works really well. You get to know your patient, and also from the point of diagnosis, everyone's triaged in terms of how their pathway is going to look. So for some, they won't even hit secondary care. They're deemed palliative. So we can get all the right teams involved at that point. Emission avoidance, we do a huge amount of work with that. So it's a model that works really well. And actually, you've only got one specialist in post, but that is working really closely with and educating and things like that. So it's a really good model.
Great to hear.
Yeah, I was going to say thank you, Tracy, for sharing that, because I think it's just in terms of lifting people's spirits, it's good to hear that there is examples where these kind of roles are kind of making an impact and can kind of function despite the sort of surrounding kind of pressures of the health service, and the sort of the current pressure of the health service is still, still functioning despite that, although you can't be entirely insulated from that, as you've described, in that the surrounding structures aren't necessarily there to support you to do things as well as you'd like, perhaps. But I still think it's good to hear where there's examples where things are going well and people are still managing to provide the care that they'd like to provide, whilst also accepting that that's not the reality for many. So yeah, it's good. I guess it's good to hear both sides of that in a way. And I was just thinking back to your slides, Teresa, about starting where you are and using what you have and doing what you can. I think that's a really good kind of takeaway message from this discussion in a way, in that we kind of accepting the sort of limitations of the system at the moment, the fact there isn't additional funding coming, and we're all working in very sort of difficult kind of circumstances in terms of resources, but I guess it's about how you make the most of those resources that you do have and use them in the most effective way, which feels to me like the most important thing at the moment. So I think that's a really good takeaway message.
Yeah, I think it's really important because we know that you're probably meeting people with cancer anyway, so they're showing up anyway, you're working with them anyway. But also we know that there's a lot of waste or a lot of missed opportunities. So if things can be even tweaked slightly or improved slightly, it might actually make a massive difference. And it's about using those opportunities, I think, as well. You know, Pip, what you were saying about doubling up on things where there are potential opportunities. One of the things we were talking about is where SACT is being delivered in communities. Is there also opportunities to build that kind of wraparound psychosocial support at the same time, so that kind of people are having that holistic support while also getting their treatment, rather than it needing to be kind of, you know, a couple of different appointments in different places with different people. But actually, if you can join up some of those things just to try and make things more efficient. But yeah, absolutely. Yes, using what you have and starting where you are, I think is key.
Yeah, I'm also going to go back to Jackie's point around the kind of cancer care review and the core funding going and the kind of impact of that, which I think is significant. But again, I think it's about thinking about other opportunities to support those groups of patients. So they'll still be coming in for largely anyway for other long-term conditions or other care that they need from primary care. So again, I think it's about trying to utilize those opportunities effectively as possible. Tanya, did you want to come in?
Yeah, just in terms of that, something really reassuring that we found locally is that where practices previously were doing the cancer care reviews really well, they are actually still doing them because they see the value of them. It's the practices that were maybe using it as a bit of a tick box exercise. So we've been really reassured by that locally, that it hasn't had the impact that we thought it might have had, which is really great.
And that's really interesting to hear. How are you collecting that data out of interest?
Well, it's anecdotally, so you know, I don't think we could really prove that, but just from what we hear on the ground, and I suppose from things like the CPERS, you know, that hasn't really dropped particularly.
Okay, that's really interesting. Thank you. Teresa.
Yeah, I just wanted to add as well, you know, in terms of some of the data that we've seen around supported self-management, and I guess that's another thing to recognise. We do, so the University of Southampton have done a lot of work on Horizons and CREW, big cohort studies with thousands of patients, and they have identified that, you know, up to 60% of people should be able to self-manage with appropriate support. It's just reflecting on one of the comments there about really meeting the more complex patients. If digital can work, if PROMs and PREMs come into practice, if we can link in better with voluntary services, the idea would be, I guess, that a lot of people would be expected to self-manage, and that a lot of people could self-manage potentially through the use of digital and other resources. So I guess the idea is that it might just be that it's those people at kind of more of a targeted or specialist level of need that would need to be seen more regularly. But it's about supporting the self-management, I guess, isn't it? And setting people up on the right pathway and making sure that there's still someone for them to call. But it mightn't always need to be clinicians and things like that. But and that's again what I mean about the kind of right person at the right time. They mightn't always need the level of expertise in terms of clinical skill, but they just might need a bit of support and guidance and signposting. So it's about almost triaging people in that way and making sure that the really specialist support is given to the people with those specialist support needs, and like the group that Pip works with as well.
I think that'd be a very interesting discussion for another meeting, actually, around that. Because I agree, I think the sort of direction of travel, not just for cancer, but probably for most of healthcare, is in that direction. And I think it doesn't come without quite implicit challenges around health inequalities and access. So it would be, I think, that would be a really useful discussion for a future meeting.
A huge change in what's expected of patients as well, I think, and not necessarily with the buy-in or the awareness of patients that that's now expected of them, so which adds to the challenge. So I think there's kind of almost like a culture shift that has to happen with it, but increasingly we're seeing that that's what's expected of people, and that's that's a kind of a undercurrent of all the policy that's being written, that people will be able to get on with things themselves to a certain extent, for right or for wrong.
Yeah. Okay, any final comments or anything else that anybody would like to add or ask or mention? Okay, thank you, everyone. Thank you, Teresa, for stepping in at the last minute. And I think you've presented the neighbourhood framework and the topic in a very helpful way for us to really get our heads around what it's potentially going to look like, and we've had some nice examples of what that might look like in the future. Oh, I can see someone's got a hand up. Sandra.
Just quickly, I joined the meeting late, so will you be able to share the presentation? Is this meeting recorded as well? Because I think I really want to go back over it and have a listen.
Yeah, yes to both. So I will share the link to the meeting recording once it's available, but I can share the slides kind of later on today, so you'll get those first. So
and just to add as well, we are publishing a kind of a document that outlines our approach that we're taking in Wessex, so we will have that online soon, so we can share that through this network as well, which might add some more context to what I've been talking about.
Yeah, thanks, Teresa. If you can share that with me once it's available, I can get it to the group. And also on that note, just to mention, we've just finished a piece of work around cancer care review and personalised cancer care in Wessex, with some kind of recommendations around sort of future working, and obviously linking into neighbourhood working. And that's published. It's due to go on the website very soon. So again, I can share the link to that with all of you.
It's there. I saw it last week.
Okay, I thought it wasn't there yet.
Yeah, I saw it the other day. Let me see if I can find it.
If you can find it, that'd be amazing. We can just put it in the chat now. So we've been doing quite a lot of thinking around other ways of making sure the cancer care review isn't happening, other ways that patients can be supported, but also wanting to support those practices who are continuing with cancer care review. I'm just kind of echoing what you were saying, Tanya. We also get that sense that what good work was happening, it seems to be continuing. And how can we support that to continue. Did you manage to find it?
Yeah, it's shared in the chat there. Yeah,
amazing, thank you. All right,
well done on putting it together.
Yeah, thank you. So probably leaves us to into the meeting. Our next meeting is in June. Possibly that would be focused on the cancer plan, sort of the session we were going to have today, but we are looking for speakers and topics still for this year. So if anybody has a piece of work or some ideas around what they'd like to see presented, particularly in relation to, I think, these sort of policy developments, I think there's lots of kind of discussions we could have in relation to them. So really interested in your thoughts and ideas, so please get in touch. Or if you'd like to present any work that you're doing locally as well, it's an opportunity. I think going back to the survey we did at the end of last year, there was a sort of even split between people who wanted a sort of deep dive like today, and those that wanted sort of a session with sort of two speakers where there's a bit more content. So we'll try and sort of mix it up a little bit to keep everyone happy. So if you've got ideas for kind of a presentation like that, a sort of standalone project that could be presented, then please get in touch. Okay, thanks everyone for your contribution, and again thanks to Teresa for stepping in and talking today. Bye everyone.